Hello everyone. Today in our series of Docplexus KOL interviews, we are honored to have with us Dr. Mala Dharamalingam, who is a reputed and experienced endocrinologist. She is currently the professor and head of the Department of Endocrinology at MSR Medical College, Bangalore. She is also the director of Bangalore Endocrinology and Diabetes Research Center. She is the ex-president of Endocrine Society of India and has worked as an assistant chairman at the Karnataka Research Society for Study of Diabetes in India. She has also received Distinguished Service Award from the Geriatric Society in 2010. Thank you, Dr. Mala, for joining us. So, when surgery and radiation don't work, which medications can be used in patients with Cushing syndrome?
It is always preferable to do surgery in a patient with Cushing syndrome and radiation. However, when they don't give sufficient results, there are some new treatments, like you can give long-acting somatostatin analogs, which is the common one that we give in Cushing's is called pasireotide. However, the problem for us is that it is expensive. The other treatments that are available are ketoconazole, which is an antifungal and actually blocks the steroid pathway. So it could be given, but it has some side effects, and they all can be given only temporarily till we can do some radical form of therapy for them. Sometimes, if they don't respond to surgery like a transphenoid pituitary surgery, you can actually do a transabdominal adrenal surgery for them.
So, how does breastfeeding help in controlling or preventing gestational diabetes?
Well, breastfeeding to a large extent possibly causes lack of weight gain, and that may in turn prevent gestational diabetes later on. There is not too much work done that if you feed your baby for a long time, that you could prevent gestational diabetes the next time you're pregnant, but it seems a probable thought.
So, among oral drugs and injectable insulin, which is safe and effective to control gestational diabetes?
For long, we have been using only insulin for controlling gestational diabetes. However, it comes with the problems of its injectable, and you have to give it multiple times a day because giving conventionally pre-mixed insulin in pregnancy does not work so well. So, we have to give multiple injections. Of late, in gestational diabetes, which is typically diagnosed after the 24th week, safety of metformin has been found. In the very mild cases of diabetes, metformin can be given if you are able to get a good glycemic control, but you will be able to get a good glycemic control in a very small segment of gestational diabetes patients with only metformin. My own experience with glibenclamide is very less because it can cause a lot of hypoglycemia. So, we are worried that we are going to have hypoglycemia in a patient who is on glibenclamide. So, I would put the patient on metformin, and if they are not controlled, I would advise insulin, and if the patient refuses, I put on metformin and then go back to insulin if the sugars are not controlled.
So, Dr. Mala, you have a rich experience. So, what is your advice to clinicians on how they can prevent the complications of diabetes, which can sometimes be life-threatening?
This is a very important question. The only data that we have, scientific data, to say what is going to help in prevention of complication is glycemic control. So, when you're looking at both micro and macrovascular complications, the microvascular complications 100% can be prevented with a good glycemic control alone from day one. That's called the memory effect or the legacy effect. So, if you're controlling from day one, later on you can definitely prevent complications. As far as the macrovascular complications are concerned, that is the ischemic heart disease or the strokes, a good blood pressure control and a good lipid control is equally essential.
So, we have often seen that women with PCOS have insulin resistance. So, why is this so and how it can be treated?
Yes, majority of the patients with polycystic ovarian syndrome will have insulin resistance. There are many causes why they have insulin resistance. Even the ovarian steroidogenesis is dependent on the insulin resistance. The treatment of it, basically, if you're looking at treatment of any insulin resistance, is diet and exercise. If you lose the weight, your insulin resistance is going to come down. Post which, if you're associated with some amount of glucose abnormalities, you could give anti-insulin resistance drugs like metformin and so on and so forth.
So, in your experience, how can we manage monogenic diabetes?
First, to understand that this is monogenic diabetes is very crucial, because we have to suspect to diagnose a patient with monogenic diabetes. Monogenic diabetes can come in neonatal diabetes. Some of it is reversible and some of it is permanent. And the common form of MODY that we know, that is the maturity onset diabetes of the young, that is also monogenic diabetes. All of them are autosomal dominant conditions. As you know, I think there are something like 16 MODYs today. There are a lot number of MODYs, and most of them are autosomal dominant. The common ones like glucokinase problems, they are very, very inconsequent, because their blood glucose will be very mild, and many of them can be treated with sulfonylureas. So, you have to take a very good history, and then if you can diagnose, now we have genetic labs doing the genetic testing. If you can diagnose, you can treat them with sulfonylureas also.
So, can you elaborate on the screening of microvascular and macrovascular complications of diabetes mellitus, especially in children?
In type 1 diabetes, if they are prepubertal and they are diagnosed very early, you can wait a while before you screen them for complications. We usually wait for 3 years to start screening them for microvascular complications, but it is sometimes we find it comes earlier also, even for type 1 diabetes. If they are around pubertal age, then we screen them at baseline itself. So, around puberty, the risks increase of microvascular complications. So, I screen them at baseline, and then every year we do a urinary albumin excretion rate, and then we do a fundoscopy.
So, Dr. Mala, you are an active member at Docplexus. So, do you think Docplexus can help raise awareness among doctors about diabetes or endocrine disorders?
I'm sure it can. I'm sure Docplexus can raise awareness, because it's a very active group. I do see people interacting, in all kinds of questions are raised, and it's a very active platform. I'm sure it can make a lot of difference.
Thank you so much, Dr. Mala, for sharing your expertise on the platform.
Thank you.
Thank you.
Thank you.
To stay updated on our latest KOL videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!